Welcome to the Medicine Science Podcast from the BMJ. I'm Cameron Abbasi, Editor-in-Chief. This week we're focusing on the NHS. On the 3rd of July, the UK's Prime Minister Kier Starmer finally announced the NHS 10-year plan. His government laid out a vision for the future of the NHS, and I think it's fair to say the reaction has been, yeah, a lot of the vision sounds good, but it's missing important elements, and there's no mention, or very little mention, of how this vision will be delivered. I'm joined now by three experts, three leading thinkers on the NHS to dissect the plan. We have Jennifer Dixon, Chief Executive of the Health Foundation. We have Katie Bramhall-Stainer, who's a GP and Chair of the BMA's General Practice Committee, and David Oliver, a consultant geriatrician and one of our columnists at the BMJ. Let's start with you, Jennifer. Can you just talk us through the outline of the 10-year plan?
Oh, thank you, Cameron. Well, it's big. It's 168 pages. It took a year in gestation. It's chock full of initiatives. I think one of the things was that the Secretary of State was frightened it might not be, quote, ambitious enough. But if you take it as a whole, stand right back, what you see is basically a sort of sensible direction of travel for the NHS over the next 10 years. But you also see that there isn't that much that's new, apart from a bit of tech, because tech wasn't available as to the extent it is now when the last sort of long-term plan was written. But I think the other big thing, apart from being overall kind of sensible but rather too full of stuff, is that there's no chapter on delivery. It doesn't look realistic that it can possibly be delivered, not least because of the funding growth is actually quite parsimonious, despite what you'd read in the press, 2.8% real terms growth till 28-29, long-term capital starvation, as Darby said, social care still not sorted and very threadbare, the staff morale being quite low, and on top of that, a self-inflicted, distractive, costly reorganisation of the Department of Health and NHS England and ICBs, all to boot. So the idea that much of this can get done is sort of for the birds, I think. However, it is a direction of travel, and I think really after the summer, people will kind of forget about a lot of it, and probably, apart from those being reorganised, and just really focus on the must-dos, which is winter and all that, and the strikes, basically. So I think nice piece of work, could be fiction. There needs to be a big dose of realism. But taken together, it's not swivel-eyed in the way that you would worry that it might be. But it's kind of makes sense. It's a bit of a melange of issues in some places. But you know, if you can deliver 10% of it, I think you'd be quite good on the current money situation.
Okay. Well, Jennifer, thank you for that. All right, let's say Labour can deliver 10% of that. What's that 10% they must deliver?
Well, I think the first thing is that there are must-dos, and the three must-dos really are delivering on the waiting list reduction politically and for morale of the staff, probably. The second is increasing access to GPs, GP care. And the third is making sure that accidents and emergency is in a much better shape, despite what winter might throw at it. Those three things are absolutely critical, at top of the list, really, for Jim Mackey as he tries to deliver the NHS safely through the winter, and more pertinently, patients safely through the winter. So I think those are the must-dos, and then, of course, quelling the strikes and so on. And I think underneath all of that has got to be the real effort to try and improve productivity in the system through technology. We'll probably get onto that later.
Yeah. Okay, so when you say it needs a dose of realism, is that saying, well, we can only deliver 10% of this, or is it something more than that that's required?
I think people have got to be realistic about the money, because the last time we did a very triumphal long-term plan at this level of ecstasy, I would say, was in the early 2000s, when the NHS received on average 6.8% real terms growth. That's over a long period. And there was less capital starvation in the system. So really, you get what you pay for, as others have said. So the realism has to be on the money. Set aside also the deficits that I think are currently around 2 billion in the system. So we have to be realistic about what can be delivered. And I think if we can just do a better job at some of those three must-dos, particularly by this time next year, we'd have been doing quite well as maybe managing the reorganisation in a way that isn't disruptive for the system.
Okay, I think we'll come back to David and Katie in a minute, but we also asked our colleague Helen Salisbury, who's a GP and a columnist for the BMJ, about what this means for general practice, and she spoke to our producer Duncan Jarvie.
The rhetoric of this is all about moving care into the community and creating these hubs, bringing together GPs and dentists and physios and pharmacies and everywhere into one place. It seems like we've heard things like that before.
Yeah, it's slightly reminiscent of the Darzi centres, the walk-in clinics that were sort of 15 years ago. They didn't work, partly because, well, actually, in some places they actually did address unmet need, which was fantastic. In other places, they just duplicated stuff, and people who got the answers they didn't like from their GP went to a walk-in centre and asked them instead, can I have my antibiotics from you? And fundamentally, they didn't save money, which was what they were meant to do. They're saying there's not going to be more money. The amount that's in the spending review is about what we need to keep on doing what we're doing now. And if you want to build lovely new centres and all singing, all dancing, multifunctional polyclinics in the community, that is going to cost some money. And you're going to have to do that before you close the equivalent services in the hospital. And it's very difficult to see how that's going to happen within the we're not spending any more promise that they've made.
And that kind of capital investment in primary care into the buildings, the infrastructure of primary care is something that GPs have been asking for a while to upgrade their facilities.
Yes, and it's not clear whether this actually will be invested in general practice. And I think lots of general practitioners are really quite worried about what they've read, because what's being suggested is that there will be these new hubs, health hubs, which will cater for about 50,000 patients. That they haven't said they're going to get rid of what's called the independent contractor status. This is the way that most GP partnerships work now. We have a contract, we look after 10 or 20,000 patients, somewhere between mostly, and we run our own show. It looks like that model is likely to be on the way out, and they're talking about something called vertical integration, which is where a hospital trust takes on these contracts and then has the responsibility for providing GP services, or horizontal integration, where groups of GP surgeries band together, they federate. None of this looks very inviting to GPs. We see ourselves ending up as salaried cogs in a big machine with no autonomy, and we don't like it. And we also feel a bit let down because there was GPs accepted a less than ideal contract earlier this year, or variations on our annual contract, with the promise that a whole new contract would be negotiated. This doesn't seem to be what we were promised, and I think people are feeling really quite cross about what's in prospect.
So to sum up, Helen, I'm taking from you as our kind of voice of primary care that there's a lack of detail here. We don't really understand what will change, but the change that's promised doesn't seem that interesting or exciting.
No, and just going back to these health hubs, I think a lot of GPs are quite worried they may end up being responsible for lots of other skilled professionals, as they're referred to in the thing, but who actually aren't doctors, and they will be supervising pharmacists and nurses and physicians associates and all sorts of other people, but not actually doing the job they trained for. And the real casualty, which is seeing patients themselves, the real casualty will be continuity of care. And the Streeting did promise to bring back the family doctor. And that's what we want. And if they've got all this money, they haven't said they've got all this money, but they do want to invest in the community. We can't quite understand why they can't just invest in general practice.
So just to be clear, we don't only have one voice of general practice. We've also got Katie here with us. Katie, are you feeling cross?
I think the 10-year plan raises more questions than it does answers. And just to step back for a moment, because I've seen lots of really helpful discourse over the past few days as this starts to percolate into the cerebral cortices of all of us who are either academics or informaticians or clinicians. I think it's important to recognise that in conversations I had with Stephen Kinnock last week and with Wes Streeting last week, they say that this is not a tablet set in stone. They've said to me, this is not a list of instructions. This is supposed to be an iterative process. And it's just as well, because I've now been qualified over 20 years. I've been a GP for almost 20 years. I've seen many NHS reforms come and go. And those that are doomed to failure are those that don't involve those who deliver it as part of a co-production and co-author and share the not just the aspirations but also the delivery. And the delivery is absent here. The detail is absent. So I think what's really important is whilst there are lots of big, bold ideas, there's an awful lot that will cause GPs concern. And I said to Wes Streeting, so what does this mean about a new GP contract? Because if you mean a new GP contract is multi-level neighbourhood providers where you're going to try and deliver continuity of care for frailty, end of life, significant enduring mental illness, those in secure settings at a stratified, cohorted patient level, that is not going to work. And if what you're suggesting is a new contract is the contractual reform around a single neighbourhood provider, that is not what was promised. And we are going to need to see that the foundations are going to be secure before you start designing these crazy modern aspirational extensions to your luxury family home. So they have committed again to negotiating a new practice contract.
This was after you challenged them.
Yeah. But I want to see the detail, because if that 29 billion at the spending review at the end of May that was passed the Department of Health, it's being decided right now where those buckets it'll be locked into between now and the next general election. And the big risk for Labour here is that if they get that wrong, and actually if what happens is just a perpetuation of the status quo, because everyone's trying to fight for survival and they're trying to actually sclerose and frustrate any transformation, and let's think about those three national objectives of, are we in support of shifting resource out of hospitals into the community? Yes, we are. Are we in support of the shift from analogue to digital? Absolutely, and GPs as digital leaders would always say that. And are we in favour of greater prevention and less reactive sickness? Absolutely. But it's how you go about that. And what we haven't touched on so far, and what Helen hasn't touched on, and what I am really worried about, is the potential threat of integrated health organisations. Because what this plan will become will be I think as Jennifer talked about, that maybe that 90% that it would be nice to have that might come in an aspirational second term to this government, and what will rapidly be a quick must do before they get to a ballot box. And if 1.7 million patients use the NHS in England every day, and 1.5 million of them are in general practice and have no other experience of any other part of the NHS, if they don't feel a difference to their local family practice, they're not going to see any result of that promise that Wes Streeting has spoken about. And Kier Starmer, they can talk about all sorts of lovely things, but if patients and voters don't feel the change, and if clinicians don't support it, it will be doomed to failure. So it's the how, it's the delivery now. And I want us to be part of making destiny a matter of choice, not chance. I want to be part of it rather than having it done to me. But there's a lot in here where we're going to be not backwards in coming forwards in terms of telling the government what we're going to need to see.
Yeah, because the rhetoric around one of the three shifts you mentioned there, hospital to community, reads as if it's hospital into community.
Yeah. It does, and you're right. So if a solution to that objective is okay, so trusts can take on the budgets for primary care, well, I'm sorry, but we're meant to be moving away from a deficit-dependent NHS, and the only evidence base we've got, and I'm a big fan of evidence base, being a clinician, is that we have evidence of community trusts and acute trusts trying to move into that primary care contracting space, rapidly realising they can't afford to deliver it, and then handing back the contracts at very short notice to ICBs, who then scrabble around to try and get primary care collaboratives to try and do the needful. But we don't know what these multi-level neighbourhood provider contracts are going to look like. We don't know who they're going to be negotiated with. We don't know what the tariffs will be or the funding within them. They talk about that £2.2 billion that would have plugged a deficit is now going to be used to fund them. It all feels a little bit back of a fag packet.
Yeah,
now, if that means it's the start of a discussion, great, let's have that discussion.
Yeah.
But right here, right now, they can't be moving ahead with this. But I suspect Jim Mackey is going to be wanting to move at pace to lock down that integrated health organisation model, especially in Northumbria. Wolverhampton's been mentioned, Somerset, parts of Leicester. That is a big existential risk, not just for GPs, but for the whole medical profession and the NHS itself.
Okay. David, let's bring you in. You're a secondary care doctor, hospital doctor. What's your take on the plan?
Well, it's not the first long-term plan I've seen in 36 years in the job. And if you go back through previous iterations, they've all said we need to shift from reactive to preventative healthcare. They've all said we need to shift care towards the community. They've all said we need to digitalise and we need to focus more on patient choice and co-production.
These are obvious shifts, aren't they? They're not controversial.
Yeah, I mean, in a way, I mean, it's orthodoxy, isn't it? It's not radical. It's health policy orthodoxy, and that's what people have been saying for years. But wanting it to happen and making it happen are two different things. And as the Health Service Journal have pointed out, there is no delivery chapter as part of the plan. And as Jennifer was pointing out, the real pressing existential challenges right here, right now. And by the way, they preface the plan by talking about what patients and what the public are most concerned about. And they tell us what they're concerned about. Access to GPs, long waits for elective care, long waits for urgent care. And those right here, right now, pressing imperatives in the service, not to mention the pressures on conventional primary care and the GP partnership model, are not really addressed in the plan. And they'd say, well, it's because it's a 10-year plan, it's not a here and now plan. And the other thing is, of course, that social care and wider local government services are deliberately excluded from it. It talks about prevention, but actually wider determinants of health are largely ignored. They've focused a bit on food regulation and early years, said nothing really about alcohol pricing, nothing about wider socioeconomic inequalities and wider determinants of health. So there's big tranches of stuff that ought to be there that are missing, not least the delivery. And I think the stuff about magical tech thinking, which you're going to come on to, I think there's a lot of over-optimistic assumptions and over-promising about that. But I'd also just like to say that because we are a medical journal read largely by doctors, there's some stuff in there, apart from the obvious hostility to the GP partnership model, I think is very threatening about medical professionalism. It's shot through with language about training people to task, not role, about not needing senior qualified professionals to do a lot of the day-to-day work, about role substitution, about substituting professionalism with AI. And if you look in the context of the resident doctors' decision to strike, which obviously goes beyond pay, the thin gruel they promised there is 1,000 additional postgraduate training places. Well, there are 76,000 doctors on the register who are in training posts at the moment. That's not going to solve the problems with training bottlenecks or morale or attrition. So, I mean, I think, the overall aspirations are good ones, but the actual delivery mechanisms for things like how do you shift resource from acute to primary and community care are lacking. And I can't help wondering why they don't just bloody fund existing primary care properly and fund and staff existing community health services properly rather than obsessing with new models that were being mooted during the last Labour government have been resuscitated.
Yeah, so this business about doctors, let's talk about that, about doctors working, they're doing the things that perhaps you want them to do, somebody highly trained professional to do. A lot of that language is You see a lot of it in management consultant documents about healthcare, talking about doctors working at the top of their license. And it seems to resonate with that to me, David. Would you agree?
Yeah, and I think it goes beyond doctors. If you read Alison Leary's thing about, work about taskification of nursing care, it's the same vision, isn't it? Highly trained professionals are autonomous, and they're challenging, and they're expensive to train. They're expensive to employ, and they're very explicit in rejecting the 2023 long-term workforce plan that was long enough in the making, because it assumes that there's going to be a big expansion in clinical professionals, and they're explicitly saying no, there's not, because we, with a combination of productivity and tech and role substitution, that won't be necessary. So I think it's part of a wider global movement to deprofessionalize learned professions. And I do find it very concerning, and I think it's a fundamental misunderstanding of the nature of professionalism and hard-won praxis. The idea that we should always be working at the top of our grade and only dealing with the most complex tasks is a recipe for burnout, but it's also a recipe for losing the very continuity of care that they're talking about when they talk about bringing back the family doctor. Okay,
I'm going to go back to Jennifer. Jennifer, what's your reaction to what you've heard? Let's save the point about tech till a little later.
Yeah. Well, I think the plan starts off with the kind of existential crisis for the NHS unless we can solve some of the supply-demand mismatch. And certainly at the Health Foundation, when we do all our analyses of future demand modelling and likely supply of staff needed, it looks really grim unless we can do something. So whatever we like or dislike about this plan, we have to come up with some sort of solution here. And the solution will have to be some kind of labour-saving, productivity, technology solution, unless there's going to be an utter culture change in the British population's approach to health. I think Katie's point is really important in that in a resource-constrained environment like this, with all the myriad of challenges on the NHS, and I confess, I know Katie said she's been around for 20 years with David, 34 years?
36, no, 36, yeah.
Well, I can beat both of you. I can say I'm 41. 41 years ago, I qualified in medicine. And if you look at how things have changed in that time, that's quite a lot. A lot of grunt work still done by clinicians that can be done by others, but actually quite a lot of other work that can be done. And if you don't have many resources in the system, as many as you would like, because the economy isn't strong enough for us, that's the basic issue here. Lest we forget, it's not the NHS, it's the economy. Then you have to cast the net wide and bring in all the talents. And what Katie said then about not necessarily being engaged enough in some of the detail is really important, because we have to do that. And we have to engage people that we normally haven't done. So it's not just the doctors or the nurses, it's also some of the people in the private sector and the data companies and so on. Because I just don't think we or any other health system is going to make it otherwise. We are in no different position to other countries, Germany, France, Switzerland. They're better endowed and they've had more investment over a longer period, but the challenges are just as blood-curdling for them. The advantage we've got here is that we have a national system where we can, at least if we are clever enough, orchestrate all the bits to be able to respond to these very fierce headwinds. So even though we can get lost in the detail about how is this going to work, how is that going to work, people aren't going to like change and all the rest of it, which is true, we have to move forward. So the question is how, and how can we engage people fully enough?
But do you think there's a realistic possibility that what Katie described is what happens, that Wes Streeting engages Katie, David, you in the delivery part of this?
I don't know, but that's what they have to do, because it's not going to work otherwise. And, Jim Mackey is going to be extremely busy over the winter trying to deliver against, looming deficits. And actually, I think the medical profession, particularly speaking as one of them, really has to step up in the way that it hasn't done yet. I would like to see the medical profession really take control, or take a lot more ownership of some of these challenges. Very difficult in this kind of political climate, which is very tribal, very polarized. A lot of stuff going on social media, which is, injuring creativity. But we have to do it, and I'm not seeing enough of it. I've never known in my time a more delicate time than now, and I think we all have to step up.
I think we could probably dissect each one of these issues for several hours each. So I'm going to move us on to talk about tech before we finish, because it's a big feature of the plan, and it's kind of the magic ingredient that solves the productivity issue that Jennifer raised right at the beginning. But I think there's a lot of skepticism about it as to whether tech and AI can achieve what the plan hopes it can achieve, because historically we haven't done so well with tech, and our technological plans and ideas and digital plans have not materialized in the way that they were intended. What do you think of that, Jennifer, having looked at the plan? Is it overambitious in that regard?
I think it's a direction of travel that is not insensible, and it's right to chart out what might be possible. It's also right to be optimistic. It's also right to be skeptical about this. There's quite a lot of techno ecstasy around, possibly linked to private conflicts. But technology really, I think the reason why it's such a central piece of the plan is because it is one of the biggest hopes for all health systems, that we'll be able to improve quality for what is likely to be a reasonable period of sluggish economic growth. So it really is on all of us to try and make this work. At the moment, there's a real imbalance in the system, just standing back between the investments and interest and hype about innovation and discovery, particularly at the life sciences end of the spectrum, which we certainly need, but compared to the service delivery and translation and the kind of labour-saving kind of technology that we need, as opposed to at the other end protein folding, for example, or pharma development.
Yeah.
So I do think there's more. So I think translation, implementation, funding the change, not just the tech, and paying attention to the people who will embrace this if it's done properly. If it's just done too, as Katie was saying earlier, with other reforms and people aren't engaged, then you can see, particularly with the potential disruption of this to people's livelihoods, that the fear factor, the safety factor will be pulled out, and that will be a block to change.
Okay, I think before I go to Katie and David, let's hear from Helen Salisbury again. You just called it techno ecstasy. I quite like that. Let's see how Helen Salisbury describes it.
There's lots of what's been referred to as techno-salvationist bollocks.
Katie.
Yes, right.
Is that what it is?
I think there's a bit of a mismatch between the honey-coated, silver-tongued promises from the tech bros to government and actually what's realistic on the ground. If we look at the bulk of expense of patients that stay a long time and have enormous amounts of unmet need, they are the same patients who are going to really struggle to engage with digital processes. So you might have disability or joint conditions or arthritic conditions that mean you cannot navigate your smartphone. You might not have literacy standards or a command of the English language to be able to engage with it. You may be partially sighted, or you may have socioeconomic deprivation that means you're not able to engage. You may lead a very chaotic lifestyle, homeless, significant enduring mental illness. All of these patients are, or end of life, or complex frailty, multimorbidities. These are the patients to whom we need to really wrap the NHS arms around. Now, if you are well, if you've never had need or cause for continuity of care, and you've only really ever required episodic, simplistic interactions with the NHS, then bully for you. Fantastic. This is going to be great. But actually, those often are the people who actually are the absolute tip of the iceberg in terms of cost and resource and attention and requirements. And the unmet need below the surface is what we're going to have to do well. Now, if the NHS app improvements mean there's greater consistency of approach, there's much less of a postcode lottery, there's much more of an even playing field, brilliant. But the last time I used the NHS app, it was actually quite clunky, and I found it quite hard to navigate. And I would argue I've got really good subject matter expertise in how to navigate the NHS.
Yeah.
So my mum she's 76. She's been on the phone this week panicking because her high street branch of her bank has now closed. But it's okay. There's a telephone number to guide you through how to use the app. She won't even engage with that. She rings me, and obviously I've got all the time in the world to be able to sort things out like that because I'm ideally placed being a GP. But the point I'm making here is that there is still going to be a need for a physical front door to the NHS. And if we hope and how we aspire that 60% of the workforce will be sorted out via an app, so much of this is untested. I'm not saying it's not going to happen. I'm not saying it's not going to be a game changer. But if we're going to do this, we've got to do it right. And that means properly getting MHRA licensing around lots of avenues. Where is the data stored for those scribes? How can we interrogate how safe it is? I want to see much more of an evidence base, much greater scrutiny of what these promises are, because at the moment I don't want them to take the government for a ride, and I worry and I fear that they are.
Yeah, we've just published an editorial by Jess Morley and Lucinda Hyam and others. I don't know whether you've seen it or not, but two issues they highlight. One is the number of people in the UK who don't have access to the internet, 1.6 million people, that's adults. And also the point, I think, which is a very valid one around AI, which is that inherently it's the training data are themselves biased, because research inherently is biased because it doesn't include women or ethnic minorities, and so the recommendations that it will produce may be misleading and potentially harmful, and they give examples of that. David, how do you feel about the technology side? I mean, we published a piece, I always mention it, I think last year in the BMJ, where a GP saying, don't talk to me about AI, just get my computer to work.
Well, no, I think that's true. I mean, first of all, Katie's concerns about digital exclusion of large groups of people who are actually quite high users of services is exactly right. So we have to address that. I think the app as an end in itself seems to be shot through the thinking, doesn't it? It's like a self-defined goal that the more people are using the app, the better. But in principle, the app as an enabler of care, fine. In principle, the idea of having much more interoperative records that patients can access, I don't have any problem with that. In principle, the idea of artificial intelligence as an enabler of better care and better predictive analytics and a time saver for professionals, fairly non-contentious. They're pushing wearable technologies, which I have significant concerns about because they just surface a load of demand that then comes to the NHS's door. But as Katie says, the stuff, it's almost like the same standards of rigor required to evaluate a new medicine or medical device don't apply in this case. So I think if we're going to push this stuff, it has to be rigorously evaluated and we have to be vigilant. And I think there are vested interests pushing it. And there's certainly magical overpromising based on flimsy evidence at the moment. If you look at, Luella Vaughan was saying on Twitter the other day, if you look at the percentage of people at the moment who use the NHS app to book appointments or do repeat prescriptions, or in fact the uptake of the NHS app since the pandemic peaks finished, it's relatively small, isn't it? So, I think obviously we do need to digitalize, but we've got to be cautious about all of those risks. And the other thing they're pushing is polygenomic screening, which opens up a whole kind of ethical concerns, which we probably haven't got time to get into. But again, blind faith.
So Jennifer, sorry, I'm going to come to you. Would it be fair to say, I think we agree with you, we aren't going to get there without technology and AI, but we need to dial down the rhetoric, the hyperbole around it, and it's not the only way. It's not deliver where we need to get to on its own.
Yes, I agree with all that. I think the clinical people and the patients have to be very heavily involved in adapting some of these new technologies and testing them. I think we need much more innovative ways of testing at scale to move forwards, and the universities aren't really coming up with those methods. So I think there's a very big issue there. But just maybe two quick other things. I think if we get very gold-plated about safety, which we should, There is also a risk that people use technology that isn't. We are so slow to take it up. People start using other technologies. So I read a study. You probably read it 18 months ago. 18 months ago, 20% of GPs were using ChatGPT-4 to help diagnose and to diagnose patients. That's probably now 50% now. So in the absence of something else, they're using that. So that's one thing. And then the other thing I just feel, and now my fellow guests will pile into me at this point, is that the tone of this conversation is, we can't do it because of this we can't. We've got to do this first. And we do with these technologies, but I think we have to flip our leadership over as a profession into let's try, we are going to adapt it and make it work. That's not over optimistic. It's just leadership. I think we have to start saying that and try to understand why we are saying we can't the whole time. What's the issue here?
Can I just challenge that? 'Cause I don't think that's. Yeah. I think that's not how the plan presents it. I mean, I would say. I think if it presented it in that way, I don't think you'd get dissent. I think what comes across is that,
they've overclaimed.
Exactly.
They've overclaimed. We're going to put the boot
exactly.
in. Understand,
exactly.
and I completely sympathise.
Yeah.
And especially if we haven't been closely involved, absolutely guess it.
Yeah, I mean, if it had been presented the way you've described it, I'm sure Katie and David would be right behind it. Katie.
Yeah, well,
I'd also say.
Sorry, David. Then
some
Katie.
Of
Then
the biggest quality improvement initiatives I can think of in my career around, for instance, transformation of hip fracture care or stroke care, for instance. There's been a very strong element of clinically driven, clinically led change.
Yes, exactly.
If you look at who was on the working groups for the NHS plan, there were a few doctors, there were hardly any nurses. The doctors that were there were largely people not in clinical practice. It's not clinically owned and not clinically led and driven. It's been written by policy wonks, senior NHS managers, etc., and then presented to us. So I think yes, absolutely, Jennifer, we don't want to be just moaning and being negative. But the reason, for instance, the GPs embraced the digital before secondary care, that it was driven and owned by them, wasn't it? And that's
yes. And just one slight pushback. So we've done quite a bit of analysis on just AI now, and we looked at what the colleges have done and the Academy of Medical Sciences and so on. And I have to say, it's not very much on artificial intelligence. It really isn't. And if I'm not in government, and I'm not directly engaged in the 10-year plan, but if you look at the leadership of the medical profession in AI and the colleges and so on, and you see what's coming at us, and you don't see enough movement, you have to then start moving. So that's still not a reason why, David, you're quite right, that enough people weren't engaged, and Katie's point as well, absolutely well taken. But you have to say, where is the leadership on this stuff?
Okay, well, let's ask a medical leader. We'll come to Katie, giving you the last word on this.
Thank you. So the really critical point is, you're absolutely right, Jennifer. I think it'll be over 50% of GP practices are already involved in using this, but they face unlimited liabilities if anything goes wrong, or if with these untested, unused models. Now, NHS England published a paper on the 9th of June around the checklist of what needs to be done. But actually, that's where they could actually do it once and have recommended providers, for example, rather than expecting 6,331 teams to do it de novo themselves. And also, a must-do in the 10-year plan within this Parliament is to deliver a single care record. And again, a really quick fix would be to extend NHS resolution to cover the liabilities around data sharing and information governance for practices, and yet they haven't done it. And if they're going to instead force primary legislation and waste an act of Parliament, well, I think there's lots of conversations to come there too. So, but as you say, it needs to be a two-way conversation, and the start of it, not the end of it.
Okay, very good. I'm going to finish with a quick fire round. We'll start with Jennifer, David, then Katie. 2 questions. The first one is, marks out of 10 for the plan. You can give your reasoning. And the second question is going to be, what would you do next? Jennifer.
I give it 5 out of 10. Not because it lacks ambition, but it lacks realism. So it sort of has an unreal quality to it. But it's 5 and not 1 because most of it isn't swivel-eyed. And that was what I was worried about. And the other question was, what would I do next? I would concentrate on the must-dos And I would pick one or two areas of the plan that are the most high priority and do some very careful thinking and planning on that basis, bringing in a bigger tent, in particular the clinical professions who are going to have to do quite a lot of this work.
Thank you. David?
I'd give it a 5 as well. Some of the stuff in there is very good, but apart from the lack of focus on delivery, and I take Jennifer's point that it does highlight the urgent existential challenges, but it says very little about acute and urgent care, nothing about public health or social care of note, and so there's a lot of stuff missing in there. But I think there's a lot of ideas that are commendable. It's just the delivery mechanism and funding streams are not there, and I think there's over-optimistic assumptions. And also, the lessons of recent history. We had a 10-year plan, we had a 5-year forward view, etc., and they didn't survive the next general election, did they? So it leads me to be a bit skeptical.
What are you going to do next? What would you do next?
I think we need to fix the here and now for this coming 12 months around urgent care falling over, around primary care falling over, and probably speed up social care reform rather than kicking it into the long grass till the end of this parliament. I think the plan is secondary because it is a long-term plan.
Katie?
I don't think I'd give it a grade, but I'd put a note in the pigeonhole saying meet me after class. The additional roles reimbursement scheme needs to move into core practice funding. That's a way of creating new money without actually having any new money. So get your foundations right. We need rapid practice level reimbursements to employ additional GPs. We've got over 1,000 unemployed GPs. And when the next tranche of GP trainees complete their training in about 2 to 3 weeks' time, we're going to have even more. And I have repeatedly warned Mr. Streeting about this. Any money for the single neighbourhood provider needs to be new and additional. We can't simply rebadge what already belongs to practices in primary care networks. A new GP contract has got to be delivered, otherwise promises are broken. And we will not be backwards in coming forwards to the public and saying the government that promised to bring back the family doctor has broken it.
Okay, listen, thank you so much. I really enjoyed that conversation with you. I think what we can all agree on is that I think all of us here do want the NHS to succeed and are willing to work together and with whichever government to make that happen. So thank you for your time today. That's it for this episode. We'll be back with a special interview with Gillian Leng, who will be talking about her review into the thorny issue of physician associates. Until then, I'm Cameron Abbasi. Thanks for listening.